All right, let's do this. Welcome to our high-yield boards blitz for head and neck radiology. We're talking rapid fire, just the critical, testable stuff you absolutely have to know. No fluff, just the essentials.
So you're here to crush the head and neck boards, right? Well, you've come to the right place. That's exactly what we're about to do.
The game plan is simple. A lightning-fast review of the signs, the pathologies, and those little staging pearls that, just love to show up on test day. Okay, let's jump right in.
All right, first things first. We've got to lock down the foundational anatomy and the classic patient profiles. I mean, this is the bread and butter for pretty much any test question they can throw at you.
You absolutely positively have to know your cervical lymph node levels. So let's make this easy. Think about the anterior belly of the digastric muscle. That's what separates level 1A from 1B. Got it? Okay. Next, the stylohyoid muscle. That's your border between 1B and 2A. And finally, the big one, the internal jugular vein. That's what separates 2A from 2B. Just lock those three borders in your head.
Now, test questions just love to use those classic patient profiles. So if they're talking about floor of the mouth squamous cell carcinoma, your brain should immediately picture an older patient, classic smoker and drinker history. But, and this is a big but, if they mention a younger patient, you need to be thinking HPV-related SCC. They love to test that distinction.
Okay, classic scenario time. You're looking at a scan and you see a nasty necrotic-looking node in level 2. So, what's at the very top of your differential?
Now, I know what you're thinking. It kind of looks like a branchial cleft cyst, right? But you have to remember that classic profile we just talked about. In an older patient who smokes and drinks, the money answer, the board's answer, is metastatic floor of the mouth SCC. Do not mix those two up.
Okay, building on those clinical scenarios, let's nail two classic pathologies that are practically guaranteed to show up. I'm talking about laryngeal cells and vocal cord paralysis. You gotta know these cold.
So what exactly is a laryngocele? Well, it's pretty simple. It's just an air-filled dilation of the laryngeal saccule. And you might be asking, what's a saccule? Just think of it like the appendix of the laryngeal ventricle. So why does it dilate? It's usually because of some kind of ball valve obstruction right at the neck of that saccule.
Now, what's in the dilation actually changes what we call it. If it's just filled with air, hey, that's your classic laryngocele. Simple enough. But if it's filled with fluid, or even pus, especially if there are signs of infection, now you're looking at something different, either a saccular cyst or a laryngopyocele.
Okay, listen up, because this is probably the single most important, most testable fact about laryngoceles. Why do they get obstructed in the first place? Well, in 15% of cases, that's a big number, the obstruction is actually caused by a tumor. You have to remember that number, 15%.
All right, let's switch gears to vocal cord paralysis. The one imaging finding you absolutely need to recognize is an expanded ventricle. But where? On the same side, the ipsilateral side, as the paralysis. That's the key.
So you see that sign and boom, you make the diagnosis, vocal cord paralysis. But what's the next step? This is crucial for a test question. You must check the chest. Specifically, you're looking at the AP window for any mass or node that could be compressing the recurrent laryngeal nerve along its path.
Okay, time to get into the nitty-gritty of laryngeal cancer. We're going to follow the anatomy, moving from top to bottom, and we're starting with the real problem area, the most aggressive region, the supraglottis.
Yeah, supraglottic cancers are just plain bad news. They're way more aggressive, they jump to lymph nodes early, and they just love to invade the pre-epiglottic space. Here's a super valuable clinical pearl for you. Because they don't hit the true vocal cords early on, hoarseness is not an early symptom. The patient might not know anything is wrong for a while.
So why is invasion of that pre-epiglottic space such a big deal? Well, think of that fat pad as being packed with lymphatics. It's basically an invasion highway for the tumor. The second it gets in there, it can spread like wildfire, and it immediately upstages the cancer. It's a game changer. Okay, so we're moving down from the aggressive supraglottis. Now let's talk about the tale of two very different tumors, those that arise from the glottic and the subglottic regions. I'm telling you, their behaviors could not be more different.
Man, this comparison is pure gold for your board's prep. On one hand, you have glottic cancer. It's the most common, it grows super slowly, it gives you early hoarseness so it gets caught, and it has the best outcome. Easy enough, right? Then you have subglottic cancer, which is the complete opposite. It's the least common, it's way more aggressive, it's often silent until it's too late, and it frequently shows up with bilateral nodal disease, even mediastinal metastasis. And yeah, that means a much poorer prognosis.
Just a quick flashcard term for you here. If you see a cancer that actually crosses the laryngeal ventricle, involving at least 2 of those different subsites we just talked about, that's a transglottic cancer. All you need to know is that it's a sign of really aggressive disease.
All right, we're in the final round now. These are the absolute make-or-break radiological findings, the ones that have huge implications for staging and for surgery. Pay close attention here.
So for tumors like nasopharyngeal carcinoma, you have to check the skull base. Normally, on a T1-weighted MRI, you see this nice, bright signal from all the fatty marrow in the bone. But when a tumor invades, poof, you lose that normal bright signal. It gets replaced by dark tumor. And just remember, for this specific job, MRI is way, way better than CT.
So here's a great question. How can you tell if a vocal cord is fixed just by looking at the pictures? Well, you look for 2 key signs. First, is the tumor actually invading the cricoarytenoid joint? And second, do you see sclerosis or some weird enhancement of the arytenoid cartilage itself? If you see that, you're thinking fixation.
And what does that finding mean for staging? It's immediate. The second you see fixation of the vocal cords, you know you are dealing with at least a T3 tumor, no question. And here it is, the absolute final unbreakable rule you have to know. Invasion of the cricoid cartilage is a contraindication to all types of laryngeal conservation surgery, all of them. And why is that? It's because the cricoid is the foundational ring of the entire larynx. It's the only complete ring. Without its stability, you just can't reconstruct the airway. It's a non-starter for the surgeons.
Okay, and we're going to end with this one final challenge. You're looking at a CT. You see definite tumor on both sides of a laryngeal cartilage, inside and out. What does that one finding definitively confirm for you? The answer? Transmural cartilage invasion. It is the single most reliable sign. And that's a wrap on our high-yield blitz. Hope this helps.